important to remember. Duration of action, which is what I just talked about, is just how long is that drug going to affect? And that is important, like Valium. When we talk about neuromuscular blockers later, we need to know that. And we need to know if we're given a sedative and a neuromuscular blocker, I really need to know something about the half-life, the duration of both of those, right? Am I going to outrun my coverage with one versus the other? Okay? So a lot of these build on each other. Termination of action, basically the time the level in the body drops below what my minimum effect is to cause the effect in the body, okay? Some of those are not as obvious. We're talking in terms a lot of critically ill patients, probably hemodynamic instability, but that can also have an effect like if I give an antibiotic, it's going to determine have I dropped below what we call minimum inhibitory concentration. Once I'm below that, then the bacteria may have a chance to grow again. So it affects how I dose my drugs, okay? Therapeutic index, this just gives a relative example of safety, okay? Anybody here working on hazmat teams? Yeah, okay. So you all deal a lot with LD50s, don't you? Right? A lot. So LD50s is the amount of drug that will take to kill 50% of the population. Okay, or the dose that will kill half, may not kill half of the world, but that above that dose, it may kill those people. The ED50 is the effective dose for half of the population. Okay, real quick historical study before I was born. When Valium came on the market, you have to understand at that day and time, the only thing that were really out there for a lot of anxiolytics were things like barbiturates, which were historically very dangerous, right? Long half-lives, very toxic. So when Valium came out, there was actually an editorial written in Journal of American Medical Association that said this is a wonderful drug because the amount of drug it would take to kill you would be like a dump truck full of the drug. That's how much it would take to kill you. It's in terms of grams. Now, you mix it with alcohol, totally changes the equation, doesn't it, right? So we do have to think about that. All right. This is another, not that all of it's not important, but this to me is a key thing when we're dealing with critically ill patients, and really patients in general. When I talk to our residents when they first get to the hospital in July, I talk to, the first day, I'm like, hey, did your parents ever read Dr. Seuss to you? A lot of them are like, remember that. And I know there's some energy around some of the stuff Dr. Seuss wrote later, so I'm not even advocating any of that. But for just simplicity for his children's books, did anybody ever read One Fish, Two Fish, Red Fish, Blue Fish? Fantastic literary piece, right? So I always think about it in terms of drug therapy. Is one fish, two fish, red fish, blue fish? Are they old or are they young? Are they big or are they little? Do they pee, do they not? Are you running to a dialysis center? Or is this somebody that's, you're at a walk-in clinic and they're a normally healthy person? Are they on lots of meds or they're on no meds? Do they have any allergies or do they have no known allergies? Okay? A quick and dirty that gives me an idea about that person. Weight. Medications are typically calculated on things like ideal or total body weight. Adjusted body weight is one that you should probably get in your vernacular, okay? I will tell you, and there's a few times I get on my soapbox in here, and this is one of them. There are protocols in certain counties by certain medical directors that are one size fits all. I vehemently disagree with that, okay? If you have a teeny granny, she is not going to require the same dose as me. I've had a few biscuits in my life, okay? And so one size fits all is a recipe for problems, okay? You can always phone a friend, medical control, okay? And so if you've got somebody, one fish, two fish, red fish, blue fish, if it's a tiny old fish, I probably want to not use a higher dose. Okay, and if I've got a really big grouper, I may need a higher dose. Okay, so I'll get off my soapbox. That's one of the ones you need to think about.
What's the difference between ideal and adjusted?
Great question. So ideal body weight, and by the way, there's even debate about this, Stephen. But some of the ideal body weight stuff is for the general population based on height. Is in your age, then what should your weight, in gender, what would your weight be? Okay, that would be your ideal body weight. total body weight is we are what we are. An adjusted body weight, we actually use this a lot on some certain drug dosing, okay? But an adjusted body weight, if they are more than 30% of their ideal, okay? On certain drugs, we'll use adjusted body weight, which will equal total body weight minus ideal body weight, that's a W, multiplied times 0.4, and then add it back to the ideal body weight. So case in point, there's an antibiotic called daptomycin that we use sometimes for gram-positive organisms, staph organisms, endocarditis, stuff like that. But if we use, sometimes we're using a normal dose for like blood infection or even a bone infection, be 6 to 8 milligrams per kilo. So like I had a patient last week that weighed, I think 150 to 170 kilograms, okay? So if I did total body weight based on that, my risk of developing rhabdomyolysis and renal failure actually increases precipitously. So I actually will use adjusted body weight on that instead of total body weight. And it varies by drug. I'll just tell you, the literature's just now gaining ground on what we should do with obesity dosing, okay? But that's a long answer to your question. That's where adjusted body weight comes in.
Because I'm seeing a lot of ideal body weight for a lot of drug dosages.
Mhm.
Lots are doing it, and then it's getting out to places
Yeah.
as ideal body weight
Yeah.
dosing to go along with the ventilator settings.
Yes.
Well, because your lungs don't get proportionately
And that,
bigger.
correct,
with-
I
that's
get
actually
the
the key.
vent.
Yeah, and part of it, when we talk about distribution, even though a patient's body habitus may be large, the drug itself may not be that widely distributed. And so that's part of what may affect that. So you raise a great point. Some of the dosing you see, and this is why I love these apps, like Lexi, is it might say so many mg per kg on ideal body weight. Because, and here's the catch-22. If I give something on ideal body weight, I might underdose it. If I give it on total body weight, I may overdose it. So that's where adjusted body weight may be a benefit. So I would love to tell you every drug will know exactly which one, but that's where having some of those charts, or at least anticipating. Does that help?
Yeah.
Okay.
Do you use the ideal body weight of 154, like it's in the book, or is it, how do you?
Well, it depends on the person, and that's what I'm saying. There's actually charts. There's like demographic charts for age and height. Okay, and again, that may influence like body mass differences, even for male versus female. Okay, may differ. Okay, all right. I'll kind of go through these kind of quickly. Again, these are all things that may affect drug responses. So environmental, best example of this, I'm just going to say is ketamine. It can have, it's similar to like PCP or LSD as far as chemically. And so if we give it, it'd be nice to have it in a nicer, quieter atmosphere. We'll talk about ketamine a little bit more later. An EMS scene or the back of a medic unit or an ER is not always the quietest place, is it, right? Time of administration, when did they eat, obviously, is going to be kind of important. Obviously, now with stroke protocols, we're always wanting to know what was that last known normal, right? You have to be careful about that. I kind of joke around. I've had a couple of family members go, well, Roy ain't been right since probably the 60s. No, I need to know when is he different than he was now, right? Overall condition of the patient. Remember the doorway? They taught you probably in EMT school, right? What does that patient look like from the door? Okay. The acronyms LGFD looks good from the door, right? So they're generally healthy, or they don't look really well. Or they LLSFD looks like shishi from the door, right? Okay, things like that. Patient in shock, we kind of talked about that can affect what route we're using, okay? And then hypothermia, we're going to shunt a lot of blood to the central part of our vasculature. So again, peripheral may not be great with somebody that's hypothermic, okay? This one is probably, let's see, Genetic factors, I'm gonna be honest with you, this is just one to consider. We're really not gonna know this a lot of times, okay? If you've got a frequent flyer that maybe has some sort of developmental disorder in your first go, you may be aware that have like a metabolic or mitochondrial effect. Sometimes it's a medical alert bracelet. A lot of times it may be mom or dad telling you, oh, they have XYZ. Okay, I need to know that, right? You know, pregnancy, there's older scales that were based on like ABCDX. There's newer stuff now that the FDA uses, and this again, also I like Lexi, where it just talks about pregnancy considerations, okay, or breastfeeding considerations. I'm not dealing with one, but I'm dealing with two patients at that point. So you know, but if mom decompensates, I can't have that because that's going to definitely affect her unborn child, right? So there are scales. Biggest thing, and the only other population I don't deal with a lot other than pediatrics is OB, except for on the weekends I work. I want to know what trimester they are, right? If first trimester typically is the most critical because everything is being formed, all right? Second trimester is more feed and grow. Third trimester is feed and grow, but third trimester gets me towards delivery, which can have impact on sedatives. There are certain antibiotics that can cause like kernicterus if they're given close so that their bilirubin can go real high. If we give them close to birth, stuff like that, okay? Psychological, we've kind of talked about this, the analgesia, sedation, paradoxical reactions, which is not always psychological, by the way. Has anybody ever seen an elderly person have a paradoxical reaction to a benzodiazepine?
Yeah, my uncle was in the process of passing away, and my aunt was telling me that he was just out of his mind. I said, tell them to stop giving him a benzo and give him alcohol.
Yeah.
And they switched it, and they finally got him to calm down.
Yeah, and it's you know, when so I mean, obviously you've got medical background. Some people are, no, we need to give a sedative, and it's hard to predict. It's unpredictable. So yeah, you may have like that, and so we'll occasionally see that. It's like, you know, we give Manil or Papal a little bit of Ativan to cool them off, and they are wired for sound. And so, but basically a paradoxical reaction, okay? But do understand, they're not always. Now this actually leads right into this. Is it predictable or unpredictable, okay? We mentioned that most reactions are based on pharmacology, are based on, it's an extension of the pharmacology. I use the example of bradycardia. I give a central nervous sedative, it usually sedated, unless it's unpredictable. We talked about determining if the patient's high risk, what do they look like from the door. A doc I used to work with called the very young and the very old the therapeutic waterfall, is if they're really old and they have some sort of medical insult, they probably move towards that waterfall quicker. Same thing with like a neonate, okay? Versus everybody here in the room, we might, I mean, if we got septic, yeah, we might get really sick, but we have physiologic reserve, right? So those are some things just to think about. So iatrogenic, by the way, can be, it's inadvertently associated. Two examples that we really hate in the hospital. One is called CAUTIs, catheter-associated UTIs. You probably have seen those patients like nursing homes and stuff. They get septic as all get out. The other one that we really, really hate in the hospital, and by the way, hospitals are judged on these in rank, are called CLABSIs, so central line bloodstream infections. But you don't have to be in a hospital. Let's say you get called to a dialysis center, a septic patient, maybe their dialysis access got infected, okay? In interest of time, because I want to make sure we get you guys a break, these are just kind of a list of the overall unpredictable things. Unless I have a known allergy, you know, obviously allergic reactions. Idiosyncratic is that we totally doesn't make any sense. There's some drugs that can give you like a lupus-like effect, some antihypertensive, stuff like that. Cross tolerance can be for you or against you. We like use things like Valium and Ativan and Librium and phenobarbital as cross tolerant for alcohol when somebody's withdrawing on us, okay? So we absolutely use that to our favor. Tachyphylaxis is when you give drug and very quickly you develop tolerance to it, and that's one of the reasons you max out your dose of atropine at 3 total milligrams usually, is just you get tachyphylaxis. Drug dependence kind of makes sense. physiologically or psychologically, depending on the drug. Cumulative effect, sometimes you'll actually max out a drug totally, and it may be due to toxicity. Probably the best example of that's chemotherapy meds. And there's one antibiotic or an antifungal called amphotericin B that you actually max it out at a certain amount. You don't get more than that, okay? Drug interactions, most of the time, you don't know they happen, okay? But you want to pay attention to them. Increasingly, as you are in the hospital setting, we use a lot of technology when we're reviewing drug therapies. And so when you get a pop-up that warns you, it may look like the sky is falling. Well, on the front end, that's what we call alert paralysis. But think about who in here has iPhones? When you get your terms update, when you update your iOS, how do you read the 21 pages of stuff? Accept, right? Alert fatigue, all right? And it's a real thing, okay? Summation effect may be 1 + 1 = 10, okay? Valium plus alcohol, all right, may not be good. All right, real quick on these, rights of medication. By the way, in med errors, medication errors could be a total lecture in of itself. Much more attention being to it, okay? A couple things so the rights, the patient rights, right med, right indication, right dose, right route, right time, right to refuse. Okay, we need to at least be open to that and talk and find out the why behind the what. Is that a religious concern? Is that, could be that their patient, their family member, oh, listen, last time we gave Mama Ativan, she beat the snot out of us, right? We need to understand that.
Sometimes they just don't want us to do it.
Yeah, exactly. And right, sometimes less is more, right? Okay, and right documentation, which I'm preached to the choir there. Make sure you document what you do. Okay. Real quick on things about med errors. Drug shortages absolutely affect this. Too quick, well, everybody probably about 3 years ago heard about the thing that happened at Vanderbilt with the Vecuronium, supposed to be Versed, right drug, okay? I mentioned before, making sure when you're looking at those vials, because you may have a different dose, okay? It could absolutely happen, and it does. Real quick example, stories sometimes illustrate these. When I was a resident, Versed came in a lot more different vial sizes than it does now. We had thank God it didn't happen at our hospital. We were at a thing called Morbidity and Mortality Conference where they present cases, all right? And so at this particular case they presented, the patient was being electively intubated due to some increased respiratory compromise. The doc said, give me an amp of Versed, okay? So they handed him an amp of Versed. They drew it up, it's 5 cc's, gave it to the patient. What he wanted was 5 cc's, 1 milligram per ml. What he was handed was 5 cc's, 5 milligrams per ml. Patient got 25 milligrams of Versed, went in cardiopulmonary arrest and died. And the title of this case was, it's not the volts that kills you, it's the amps, okay? So amps are not always a dose, okay? I always look at them from that standpoint. Last thing is, real quick. Evaluate medication decisions by other facilities. Okay, if you're doing a critical care transport, I know they're wanting you, and hey, I work at UT, and I know, if we're shipping somebody to Vandy or Burn Center or whatever, and if there's too much fog, you're not getting them on a bird, right? They got to go by ground. You're transporting that patient. That person that you're getting them from may get annoyed at you, but I'd look at every one of those drips. I want to know everything that patient's got, and I want to know everything that patient had in the last, say, 30 minutes to an hour, okay? You may see something, and again, you may need to know when something's going to wear off, right? I need to know that you gave a pain med an hour ago, but I'm going to be at Cumberland County when that wears off, and this is a burn patient. I need to know that, right? The other thing, real quick, we have now, they do it all electronically, but our pharmacy technicians, every morning on their assigned floors, they go and look at drips. Now they can do it online and see how much is already run in, how much is gone, so they can tell our IV room when to send new drips, okay? Well, I had one of my techs that came up to me, this was probably about 5 years ago. This was during the fluid shortage from one of the hurricanes. He came up and said, hey, I just wanted to let you know, this dillet drip, it's usually 100 and 100. Somebody had put the little cap thing on a 250 bag instead of 100. I was rounding with the team that morning, I was like, well, that makes total sense, because they were talking about they had trouble getting the rate control, and they kept having to turn up the drip. Well, the reason was they were using a more dilute drip. So it was an underdose, that ultimately they got the right drug, because it's titratable. But that was a great example where, oh, okay, well, crap, it was, they put it on the wrong bag. All right, and this is one here, obviously confirm accuracy, proper labeling, that, we use a lot of tape and codes, right? That may not be a nice little label, but definitely, but if you're handing off, or if you got a bag, so make sure there's something on there to tell them what that is, okay? Line incompatibilities, I've mentioned Lexi quite a bit, I've erased it now. It's got a great incompatibility program in it that you can put in this drug and can I put it in, or it's totally incompatible, or whatever. So in Pediastat, I don't know that it has incompatibilities, but it's got drug dosages, okay? I ran a little over in that section. We are going to take a 10-minute break. Any questions on that section? And I know that part, thank you for hanging in there, because that part is not like, hey, this specific drug, we will